Let's look in more detail at the non-invasive tests we've just mentioned. Non-invasive testing has as its goals the estimate of subsequent prognosis, the determination of needs for additional testing, adjustments in therapy, and determination of exercise limitation. These non-invasive tests help the physician to categorize patients with unstable angina as either high or low risk. The tests that help to make this categorization include baseline electrocardiograms, continuous telemetry, exercise testing, and exercise myocardial imaging, also known as nuclear stress testing. The appearance of ST segment depression on the baseline electrocardiogram with or without associated chest pain has important prognostic implications, portends a worse prognosis of death, and is often a marker of severe multivessel or left main artery disease. If the second type of test, telemetry, shows the appearance of ST segment depression, this is also associated with a poor prognosis. The third type, exercise testing, provides important prognostic information. However, there are large disparities in event rates, clinical classification, and documentation of underlying coronary artery disease. A negative test is not necessarily conclusive because, unfortunately, patients with a negative stress test also appear to have a high incidence of adverse events. Exercise testing modalities include routine exercise stress testing, nuclear stress testing, dipyridamole nuclear stress testing, dobutamine nuclear stress testing, stress echocardiogram, and dobutamine stress echocardiogram. The choice of a stress testing modality used should depend on evaluation of the patient's resting electrocardiogram and ability to perform exercise, as well as the expertise and technologies available locally. Turning now to invasive methods used in non-intensive medical management. The goal of cardiac catheterization in patients with acute coronary syndrome is to provide detailed structural information necessary to assess the patient's prognosis and to select an appropriate long or short-term management strategy. Unstable angina is often associated with multivessel disease. In this case, there is a wide variation in apparent need for cardiac catheterization and percutaneous intervention, such as coronary angioplasty, with or without stenting. To date, the most effective role of interventional therapy in patients with unstable angina has not yet been fully defined. Recent clinical trials have demonstrated a modest benefit with an angiographically early invasive approach. Two strategies have evolved: an early invasive strategy versus an early conservative strategy. The first is an early invasive strategy. In this treatment, all patients are catheterized within 48 hours of admission. The other is an early conservative strategy. Here, only high-risk patients with ongoing ischemia receive a cardiac catheterization. Studies supporting an early conservative strategy include the TIMI 3B and Vanquish trials.